Myself, Dr. Anish, Professor of Department of Radiodiagnosis. My topic for today is radiography in acute abdomen. So, I'll be mainly dealing with radiography, X-ray, and briefly touching on other imaging modalities like ultrasound, CT and MRI also. So, when a patient present with acute abdomen, so these are all the possibilities a clinician will be thinking of initially. So, based on the location and of pain and other clinical finding, he may be able to narrow down to a group of diagnosis or a single diagnosis, but for confirmation, radiological investigation is needed. So, what is the role of radiologist here? So, radiologist role comes to for the surgeon to decide whether surgery is required or not required, or whether if it is required immediately or it can be done later. For proper diagnosis, so we need proper clinical details, the patient history, the clinical working diagnosis and any relevant lab investigation, so that in radiological investigation can be tailored for that particular clinical condition. So, these are the important radiological investigations which will be useful in acute abdomen. That is radiography, plain X-ray, conventional GI contrast studies like barium and other contrast studies, and ultrasonography, CT and MRI. In abdomen radiograph, there are a series of radiograph which can be done and which will be useful. The more important one is erect chest X-ray. The advantage is it is best for free peritoneal air. It is superior to abdomen X-ray, erect abdominal X-ray for diagnosing small pneumoperitoneum. The only thing is patient should be in upright position for at least 15 minutes before taking the radiograph, so that air gets collected under the diaphragm. And also being chest X-ray, so it will be useful to diagnose intrathoracic abnormalities which may present as acute abdomen. Erect abdomen X-ray, so mainly it is used to look for air fluid levels, to look for obstruction. And supine abdomen, it is best for abdominal details like distribution of abdominal gas, bones, joints, calcification, displacement of bowel loops by any masses and obliteration of fat plane. And left lateral decubitus position, it can be used as a substitute for erect chest X-ray for free air, and also erect abdomen for fluid levels if patient is not able to sit or stand. Coming to plain radiography of abdomen, so the normal plain radiograph, the appearance, few normal air shadows you should be looking at, the normal stomach shadow over there, and few air in few of the bowel loops, small bowel loops, and also gas in the rectum or sigmoid is normally seen. So normally up to 1 or 2 or up to 3 air fluid levels of diameter less than 2.5 centimeter is considered normal for small bowel. So if it is the levels are more than 3, air fluid levels more than 3, and the diameter is more than 2.5, then we can say the bowel is dilated. Coming to GI contrast studies, so you can use barium and other water soluble contrast, ionic contrast medium are there. But in suspected cases of bowel perforation, the giving barium is contraindicated, because barium is an inert substance which doesn't get absorbed. So if it goes into the peritoneum, it will cause chemical peritonitis, and if it stays there, it may form granuloma formation, and that inflammation will lead to adhesion and intestinal obstruction. So instead of that, you can use water soluble contrast, iodine based contrast medium. Ultrasonography, extremely effective for hepatobiliary, renal and gynecological pathologies like acute cholecystitis, cholelithiasis, appendicitis, and intraperitoneal fluid can be seen on ultrasound, even small amount. The limitation of ultrasound is it is not very useful for bowel pathologies, especially when bowel is filled with air or gas, and also obesity, which may hamper the view. CT is the modality of choice for acute abdominal cases, as it is not hampered by any bowel gas or any gas, or bone or adipose tissue, which is a limitation for ultrasound. It gives a comprehensive view of the all intra-abdominal solid and hollow viscera as well as peritoneum, mesentery, lymph nodes, retroperitoneum, etc. MRI is not usually required, not usually used, except if there is contraindication for iodinated contrast medium, and also in pregnancy where radiation to be avoided. And MRI doesn't have any radiation. So when a patient comes to you with acute abdomen, so these are the broad categories under which you should be thinking of. So one is perforation, bowel perforation, intestinal obstruction, ischemia and inflammation. Let us start by one. That is, first is bowel perforation. Like in image, we cannot diagnose perforation. What we can do is we should look for free air in the peritoneal cavity. That is pneumoperitoneum, which almost always indicates the perforation of the bowel. There are a few exceptions. I'll be showing that later. So when there is perforation, the bowel content will go into the peritoneum. Then there will be peritonitis and the subsequent fluid collection will be there. It is a surgical emergency. So there are a few causes of peritoneum without peritonitis. So that is a small perforation which is sealed off, that is sealed off perforation, or postoperative peritoneal air or peritoneal dialysis, and also a perforated cyst in pneumatosis cystoides intestinalis or coli. So what is this pneumatosis? Let's see. It is characterized by presence of multiple gas-filled cysts in the mucosa and subserous of small bowel or colon. So about 50% does not have any known causes, while remaining cases may be associated with other conditions like inflammatory bowel disease, scleroderma, COPD, etc. So coming to the pneumoperitoneum proper, so there are few signs with which we can diagnose pneumoperitoneum. The common or well-known finding is the air under diaphragm in a chest X-ray or abdomen X-ray erect. But chest X-ray erect is best for diagnosing even small amount of pneumoperitoneum as small as 1 ml, because the X-ray beams, which is the centering of X-ray beam will be at the level of T7 thoracic vertebra in chest X-ray, so which almost at the level of upper border of diaphragm, just above that. So almost the rays are almost horizontal or tangential to the diaphragm. So any small amount of air just below the diaphragm is better visualized compared to abdominal X-ray, where the centering will be much lower near the iliac crest. So the rays will be oblique. So it will be maybe masked by other soft tissues. And also abdominal X-ray, it is a bit overexposed, in the sense there may be black areas in the subdiaphragmatic region which may mimic air under diaphragm. So that's why X-ray chest is best. And also that may be able to show any other lung pathologies, like in this case lower image you can see the opacity in the left lower thorax. So that is a pneumonia which may also present as acute abdomen. So only catch here is patient should be in that position, that is erect position, for 15 minutes at least for the free peritoneal air to get collected under the diaphragm. Otherwise it may not show that. Left lateral decubitus position, nowadays this has almost become obsolete, but because CT and other imaging modalities are there, but still in certain situations it may be useful if patient cannot be shifted and patient is not able to sit. So we prefer to do it on left lateral decubitus, that is left on the lower side. So advantage is the pneumoperitoneum will be seen between the abdominal wall and the liver. So you can see the lucent air, and also it will demonstrate air fluid levels if bowel is obstructed. So other important sign is the Wriggler sign or the double wall sign. So normally the bowel wall will be outlined by the luminal air from the inside of the bowel, but the outside will not be lined by the air. It may be like fat or other soft tissues, but in this case you can see, so this is a bowel, this is the inner aspect of the bowel which is outlined by air, and outer aspect. Usually you will not see the outer aspect, like in this case this is a descending colon, outer aspect cannot see, but in this case it is outlined by the peritoneal air. It is called Wriggler sign. It needs a significant amount of free air in the peritoneum. The other sign is triangle sign, almost similar concept. Only thing is there will be an adjacent organ or structure in addition to the bowel. Say, like in this image you can see there is a extraluminal air which is outlined by the bowel here, and also in the upper border it is by the diaphragm. So it may give a triangle like appearance. The next important sign is the cupola sign. So here what happens is it is done in supine X-ray, it can be seen. So the non-dependent gas that rises within the abdominal cavity, it get accumulated under the central tendon of the diaphragm. So like a cupola, the lower image, you can see the upper border is well defined, lower border is indistinct. So in relation to the diaphragm, this lucency, so this is the cupola sign, air getting collected there, a lower margin is indistinct. So it is seen at the level of lower thoracic vertebra in supine view. So other sign is football sign. This is a massive pneumoperitoneum. The most of the abdominal cavity is filled with air, so it appearing like a football. Few other important signs which may be subtle but which may raise the possibility is the urachus sign. So urachus is the remnant of the median umbilical ligament or obliterated urachus. So that will be outlined by the free peritoneal air. Normally it will not be seen, but once it is outlined by the air, so then you can see the ligament very nicely. So again it is seen in supine view. Similar to the urachus sign, this is the inverted V sign. The concept is the same. The lateral umbilical ligament which contains the inferior epigastric vessels are outlined by the air. So that's why it is seen nicely, again in supine view. Similarly, there is a falciform ligament sign. Normally the falciform ligament which attaches to the liver are not outlined by any air. Once it is outlined by the air in case of pneumoperitoneum, that ligament will be seen very nicely, like in this case. The first one is X-ray, you can see the ligament, the corresponding CT, you can see the extraluminal air collection. So now you know the signs of pneumoperitoneum, but there are some condition which may mimic like pneumoperitoneum. You should not wrongly diagnose it as pneumoperitoneum. They are subdiaphragmatic abscess with internal air, and Chilaiditi syndrome, curvilinear lung collapse, and subpulmonary pneumothorax. Let's see it one by one. So Chilaiditi syndrome. What is Chilaiditi syndrome? So when there is interposition of colon between the liver and the right hemidiaphragm, like in the image. So if colon may contain air, that air may appear like a air under diaphragm. So the difference is you can see the hostrations. See the hostrations, unlike pneumoperitoneum where the air will be homogeneous lucency. So curvilinear basal lung collapse. Here there is a band like collapse is there, so that may appear like a diaphragm, and the below one may appear like a free air. The difference is you should look for the normal lung markings below this apparent diaphragm. So the normal lung markings will be seen, whereas in pneumoperitoneum no markings will be seen, it will be clear air. Subpulmonary pneumothorax. Like in subpulmonary effusion, air may get collected under the base of the diaphragm. So again it may appear similar, but you should trace the air lucency till the lateral aspect, till the CP angle. So you can see the lucency is going there, and also it is extending along the lateral aspect of the lower lung. What is the role of CT? CT is considered as the gold standard for assessment of pneumoperitoneum. It is useful in identifying even small amount of extraluminal air, particularly when radiograph is inconclusive. CT is less dependent on patient position, so it can be taken in any position without any waiting. With any perforation, outpouring of inflammatory fluid occurs, and this fluid also can be seen on CT. The cause and site of perforation may be sometime be diagnosed. So this is the CT. So you can see there is a small air lucences here. That is black thing, that is the air. This is the air within the stomach. So that is a small pneumoperitoneum, and there is a wall thickening of the stomach here. So it is because of the perforated gastric ulcer. Any role of USG? No, it has very limited role. Wherever there is air is there, ultrasound cannot penetrate through the air. So there will be artifact. So it has a limited role unless there is because of the perforation, if there is collection, that can be seen on ultrasound. So the next broader category is obstruction, intestinal obstruction. Small bowel is the most common, and colon also. Small bowel obstruction or the mechanical obstruction. So adhesion is the most common cause, and other causes like hernia, tumors, etc. Coming to the radiological signs of small bowel obstruction, on radiograph, there will be dilated gas-filled bowel loops in small bowel and multiple air fluid levels on erect film. And if the bowel is predominantly fluid filled, so you will not get that air fluid level. So bowel may appear like a sausage-shaped, oval-shaped soft tissue densities in supine film. And there is something called string of bead sign. And in small bowel obstruction, there is no dilatation of colon. No colonic air in complete small obstruction. If there is complete small obstruction, no air will go into the colon. So, but the presence of air in the colon doesn't rule out small bowel obstruction. So the role of ultrasound is, when there is a mechanical obstruction, there will be increased peristalsis. So in ultrasound you can see the advantage of ultrasound is it is real time, unlike X-ray or CT which is static. So you can see the hyperdynamic movement, hyperperistalsis, and to and fro movement of the bowel content. So this is a classical finding in intestinal obstruction, erect abdominal X-ray showing multiple air fluid level. So this is called step ladder pattern. Multiple means more than 3 and dilatation of more than 2.5 centimeter. So this bit variations in the obstruction. If the first one is predominantly air containing obstruction and the second one is predominantly fluid containing. In air containing, you can see the small bowel loops are dilated with air, and you can see some striation like this is volvuloconjunctivis of jejunum outlined by the air, and the second one is fluid filled. You can see the sausage shaped densities. So the string of bead sign. So what it is? There is, because of the obstruction, there is increased peristalsis of bowel loops. So what happens is the air foci may get collected under the volvuloconjunctivis of jejunum, so which may appear like a string of bead sign. So it can be seen in lateral decubitus and also on erect X-rays. So the other one is adynamic, that is a dynamic obstruction. This is the paralytic ileus. What happens in paralytic ileus? The peristalsis ceases and the fluid get accumulated in the bowel. On radiograph, both the small bowel and the large bowel get dilated, and multiple air fluid level may be there, and air in rectum will be there, unlike a colonic obstruction. And ultrasound, since it is paralytic, there is no movement of the bowel loops. Peristalsis will not be seen. So now this is a small bowel obstruction or a large bowel obstruction. So you can see the dilated bowel loops both at the center and also at the periphery. These are colonic loops, these are small bowel loops. So this is the colonic obstruction. So we need to know what is dilated. If small bowel and the colon both are dilated, then it is not small bowel obstruction. If both are dilated with rectal air is there, then it is paralytic ileus and USG shows no peristalsis. If rectal air is not there and small bowel and large bowel are dilated, then it is colonic obstruction with incompetent IC valve. Because of incompetency, the dilated the dilatation will extend into the small bowel also. So unlike if it is only colon dilated, that is colonic obstruction with competent IC valve, and if it is only small bowel dilated, it is small bowel obstruction. So let us see the differences. In small bowel, you will see the valvular conjunctivitis. I have shown that there are closely spaced folds in the jejunum, whereas in large bowel obstruction, the hostrations of large bowel will be seen, which are widely spaced and thick folds, and small bowel will be at the center, peripheral will be colon, and the dilatation will be more on the caliber will be more on in large bowel, and feces may be seen in large bowel as motile densities on X-ray. So what is the role of CT in obstruction? CT has proved useful in characterizing small bowel obstruction from extrinsic causes like adhesions or strangulation, etc., or intrinsic causes within the lumen, any mass, TB, etc., and intraluminal causes like Bezos or intestinal malrotation. So CT is always better. So and small fluid filled bowel loops which are difficult to seen on X-ray can be seen on CT. So role of CT is CT can provide answer about where is the site and what is the cause and severity of the obstruction, and whether the obstruction is complicated by ischemia. That is important. So there are some signs like about non-viability. If there is bowel wall thickening and mesenteric standing, etc., in an obstruction, you should raise the possibility of obstruction. So this is a CT image of a small bowel obstruction. In this you can see there are dilated small bowel loops and there is a transition here. There is a small caliber change here, but there is no mass either inside the lumen or outside the lumen. So probably it is because of the adhesion. We cannot see adhesion as such, but since there is no other cause, so it is possibly because of adhesion. What is the role of ultrasound? You can see the fluid filled distended bowel. You can see the peristalsis. If peristaltic activity is more, then it is small obstruction. No peristalsis, paralytic ileus. So cause of obstruction may be sometime seen, and if there is a gas filled, then it is difficult, and if patient is obese, difficult to visualize. I will be touching on few important causes of intestinal obstruction. First is intussusception. Idiopathic intussusception usually lack an identifiable lead point and usually occurs in children, and in adults usually there will be a leading mass will be there. So what are the findings? On X-ray you can see a mass like thing bulging into the distal. This is a transverse colon, a mass like soft tissue density bulging into the distal colon or distal bowel. So similar thing in barium enema. You can see there is a meniscus like appearance, it's called meniscus sign, and sometimes a spring of coil like appearance may be there. Same thing on ultrasound, you can see there is a mass like thing with the central echogenic area. That echogenic is white, so it is because of the mesenteric fat. CT you can see very nicely the intussusception. This is going into the intussusceptum. Midgut volvulus. When malrotated bowel, intestinal malrotation, when it twists in a clockwise direction in a narrow mesentery. So this is the midgut volvulus. So in upper GI contrast studies, you can see a corkscrew like appearance. I'll show the images. You can see this upper GI contrast study. You can see the corkscrew like appearance of the proximal small bowel, jejunal loop. The second image also corkscrew like appearance because of the twisting. The child. So similar case on CT. In CT there will be alteration in the SMA-SMV relationship. Usually SMA is on the left side like aorta and SMV is on the right side like IVC. But there will be change in the position in case of malrotation, malrotation with midgut volvulus. So second image showing a whirlpool like appearance because of the twisting. The next broad category is intestinal ischemia. On radiograph a few signs, like a classical sign is called thumbprint sign, and you may get gas in the portal vein because of the ischemia. The gas may go into the portal vein from the bowel. USG may show bowel wall edema and thrombus in SMA and SMV, but it has a limitation. Like if bowel air is there, then it will be difficult to visualize these vessels. CCT with CT abdominal angio is the answer. So it will show the thrombus in the vessels and thickened edematous bowel wall. You may have increased enhancement or absence of enhancement in the affected bowel, and intramural and gas in the portal vein are better visualized on CT. This is the image of ischemic bowel. So in X-ray you can see a thumbprint like appearance here in the the splenic flexure descending colon region. This is the thumbprint sign. You can see the air in the lucency in the portal vein. Similar kind of images in CT because of the edematous mucosa of the colon. There is a thumbprint like appearance, and on CT you can see the thrombus in the SMA. Barium enema is also showing thumbprinting appearance. Next is sigmoid volvulus. There are two volvulus, important volvulus here. One is sigmoid volvulus and cecal volvulus. In sigmoid volvulus, since it is a distal twisting of the sigmoid, there will be proximal dilatation of the rest of the colon. Whereas cecal volvulus, there is distal colon get collapsed. In sigmoid volvulus, what is known as a classical coffee bean sign. So it is because of the contiguous wall from the dense white line at the center, surrounded by the curved dilated. This is the coffee bean like appearance, similar appearance here. This is the coffee bean appearance of the sigmoid volvulus, and the rest of the bowel is dilated. And there will be no hostile markings in sigmoid colon. Sigmoid colon is devoid of hostile markings, you will not see that. Whereas cecal volvulus, you will get hostile marking, one or two hostile markings may be seen, and also distal colon is collapsed. You can see only the dilated cecum. Toxic megacolon. When colon become dilated more than 6 centimeter, like in case of Crohn's disease and ulcerative colitis, so it is a impending perforation risk is there. So you should avoid doing colonoscopy and other barium studies. So last broad category is inflammatory condition. Ultrasound has limited role here. So let us see a few conditions like acute appendicitis. Here USG has the role. Using linear array transducer, the high resolution transducer with graded compression, we can detect up to 70% of appendicitis. But there are limitations if there is overlying gas or overlying bony pelvis, and if appendix is retrocecal, so it is difficult to see, and if patient is obese. So this is the case of acute appendicitis. You can see a blind ending tubular structure which is not compressible, and on Doppler study you can see the increased vascularity because of the inflammation, and size is more than 7 mm, the diameter. On CT, the CT has more sensitivity. It may detect almost all appendicitis cases, and in addition to that you can see other periappendiceal fat changes and appendicolith. These are all better visualized, and also complications of appendicitis like appendicular abscess formation and perforation. You can see this is another case of appendicitis. You can see this is the appendix, fluid filled distended appendix. So next is pancreatitis. So here also X-ray has limited role unless in case of chronic pancreatitis, which may have pancreatic calcification. So you can see that calcification on X-ray. Otherwise ultrasound has a limited role, again limited by the gas, and also gas in the stomach, mainly stomach bed region. So you can give some fluid on table and look for pancreas, but it is difficult many times. Part of the pancreas is not visualized. CT will show pancreas and pancreas abnormalities better. So it is important to grade the severity of the pancreatitis on CT, on contrast CT. Ideally it should be done after 72 hours after the onset of patient symptom to look for necrosis. If you do early, you may miss the necrotic component. Acute cholecystitis. So in imaging, mainly USG and CT. So USG is very useful. The gallbladder is over distended. There may be thickening of the wall, and there may be pericholecystic fluid collection. CT again, like in appendicitis, the complications are better visualized on CT, like abscess formation, emphysematous changes, perforation and cholangitis, etc. Cholelithiasis, ultrasound is best for detecting cholelithiasis in the gallbladder, because irrespective of the content of the calculus, so ultrasound will show the calculus. But the problem with X-ray and CT is, since most of the gallbladder calculi are radiolucent, about more than 80% are radiolucent, calculus may not be seen on X-ray and even on CT. Unless the calculus is calcified, so it's difficult to visualize. So this is in contrast to renal calculus, where more than 90% of renal calculi are visualized on X-ray, and almost all calculus, almost 100% calculus are visualized on CT. So this is a case of cholelithiasis on ultrasound. So reflective echogenic foci with, there is a shadowing there on ultrasound. So ultrasound is better, it will detect all the calculus in the gallbladder. But in CBD it will be difficult to visualize on ultrasound. Distal CBD again is obscured by bowel gas. Like choroidocholithiasis, distal CBD difficult to visualize. CT also again, because of the density, is maybe isodense to bile, and if it is not calcified, CT may not detect the CBD calculus. Here the MRCP is the investigation of choice. So to conclude, a diverse set of medical condition can present as acute abdomen. A good history and physical examination helps one to decide upon initial imaging modality. Plain X-ray, USG and CT help to establish diagnosis in most cases, with MRI playing a relative minor role. Thank you.